Good day, everyone. This is Medicine with Mike, one source, endless knowledge. And today we'll be talking about antihelmintic drugs. These medications are designed to eliminate parasitic worms, also known as helminth, which is where the drug class gets its name from. It does this by exploiting biological differences between parasites and the human host. These drugs target pathways in worms that are absent or different in humans, effectively paralyzing or killing the worm, but not, of course, the patient's cells. By clearing helminth infections in individuals, we don't only save the individual, but we prevent transmission within the community. More than prevent, it's reduce. Today, within this lecture, we'll review the major helminth groups and the antihelmintic drugs used to treat them, focusing on the clinical use and practical advice. So there are three major helminth groups, the nematodes, trematodes, and cestodes. Nematodes are the roundworms. They're elongated cylindrical worms with a complete digestive tract. Examples include the Ascaris lumbricoides, also known as the giant roundworm. They have the hookworms, Ankylostoma necator, and the pinworms, Enterobius vermicularis. Nematodes cause intestinal and sometimes tissue infections. Now, trematodes, also known as flukes, are leaf-shaped flatworms, often named for the organ they infect, such as the schistosoma and clonorchis. So schistosoma are blood flukes affecting the blood vessels, while clonorchis is a liver fluke infecting the bile ducts. Finally, we have the cestodes. So this refers to the tapeworms. They're flat, segmented worms that attach to the intestine via scolex. This is the head. They absorb nutrients through their skin. Each group has its unique biology and life cycles, so each requires different drug treatments, which we'll go through today. Let's talk a bit about the global impact of helminth infections. So helminth infections represent a significant global health burden, affecting over 1 billion people worldwide. These parasitic diseases are especially prevalent in tropical and subtropical regions. These may tend to be regions with poor sanitation and limited clean water. Infected individuals may suffer from malnutrition, anemia, growth impairment, and chronic organ damage. As you can imagine, this is affected mostly through the nutrition and the deficiencies associated with these parasites. In fact, about 1.5 billion people have soil-transmitted helminth infections, underscoring the need for effective control measures. So efforts to control helminths often combine antihelmintic therapy, which we just mentioned, as along with hygiene, and sanitation improvements. Along with this, there are programs, mass deworming programs, which is a key public health strategy in endemic regions, distributing medication to large at-risk populations to reduce community parasite loads. Such populations are, of course, something like school children. So, nematodes. Nematodes are often the most common helminths encountered. They include the intestinal worms, like we mentioned, Ascaris lumbricoides, Trichuris trichuria, this is the whipworm, hookworms, and Enterobius vermicularis, which is the pinworm. They also include tissue-invading worms like Strongyloides stericularis, which can auto-infect and cause disseminated infection. They also have fluvial worms such as Eukaryoria bancrofti, causing lymphatic filariasis, and Onchocerca volvulus, causing river blindness. These worms can cause diverse symptoms. For example, hookworms often cause iron deficiency anemia, and fluvial worms can cause lymphedema or ocular disease. A clinical pearl associated with nematode infections is that Strongyloids infections require ivermectin as first-line therapy, especially in immunocompromised patients. This is because other benzimidols are ineffective against in tissue stages. So, bendazole. This is the first-line treatment. It is a benzimidazole antihelmintic. This is a first line for many common intestinal nematode infections. So basically, its mechanism of action is based on binding to the parasite B tubulin and inhibiting the microtubule polymerization. This prevents the worms from absorbing glucose, effectively paralyzing and starving the parasite. which is then expelled in the feces. So mebendazole is effective against a wide range of parasites, including Trichocereus trichuria. This is the whipworm, again the pinworm, Enterobius vermicularis, and hookworms, Ankylostoma and Necator. So dosing is very important, of course. It varies according to the parasite in question, the target parasite. It is given orally, typically 100 milligrams twice daily for 3 days. For basically pinworm, it's a single 100 milligram dose, usually sufficient, but typically repeated after 2 weeks if reinfection is suspected. Because mebendazole is poorly absorbed, it concentrates in the gut where the worms reside, minimizing systemic effects. Now, on the clinical pearl just mentioned on the strongyloids, this is why it is not effective, as it cannot reach the tissue-dwelling larvae. So let's talk about its safety profile now. It is generally well tolerated. This is due to its minimal absorption. The common side effects are mild gastrointestinal symptoms such as abdominal pain and diarrhea. So patients should be advised that mild stomach upset can occur and usually resolve spontaneously. Rarely, mebendazole can cause blood discresis such as neutropenia or liver enzyme elevation. Of course, its risk increases with prolonged use, so blood counts must be monitored and liver function if long courses are needed. Importantly, mebendazole is contraindicated in pregnancy. This is especially in the first trimester because of teratogenic risks seen in animals. In most deworming programs, it may be used with caution in the secondary or third trimester if benefits outweigh the risks. Now, parental pamoate. Parental pamoate is an antihelminthc drug that causes parasite paralysis by acting as a depolarizing neuromuscular blocker. Basically, it stimulates the worm's acetylcholine release and inhibits acetylcholinesterase, resulting in sustained contraction of the parasite's muscles and thus resulting in eventual paralysis. The paralyzed worms, now paralyzed, will detach from the intestinal wall and are expelled. Parental is effective against many intestinal nematodes, especially pinworms, roundworms, and some hookworms. When talking about dosing, it is given orally in a single dose, typically 11 milligrams per kilogram. This is up to a maximum of 1 gram. Its poor absorption once again limits its side effects. Clinical pearl is that a pinworm infection often requires retreatment after 2 weeks to kill newly hatched eggs, since a single dose does not eliminate eggs. It has basically an excellent safety profile because little of the drug enters the bloodstream. Systemic effects are rare. Most patients only experience mild gastrointestinal upset. This is nausea, abdominal cramps, or diarrhea, the usual. Headaches can occur occasionally, but is pretty uncommon. So patients should be reassured that these mild GI symptoms are common and will pass without intervention. No laboratory monitoring is needed. Parental can be used safely in young children and even nursing mothers. It is a single dose regimen, and safety makes it a convenient choice for pediatric worm infections. Thiabendazole. Thiabendazole is an older benzimidazole, once used for a broad spectrum antihelmintic, but is rarely used nowadays due to its toxicity. Toxicities such as when taken orally, it is often cause significant nausea, vomiting, and central nervous system effects such as dizziness, sleep disturbances, headache. Consequently, it has been withdrawn in many countries, of course. Current use, it is still currently used as a topical cream. Usually the concentration is 15%. The indication is for cutaneous larva migrans caused by a dog or cat hookworm larvae migrating under the skin. In this form, it can relieve severe itching rash of larva migrans. Systemic thiabendazole is essentially obsolete. Okay, so nowadays it's just topical. Now, ivermectin, very popular. It's a broad-spectrum antiparasitic and is the drug of choice for several infections. It is highly effective for strongyloiditis and onchocerciasis. These are which cause river blindness. Okay. It also treats cutaneous larva migrants, scabies, and lice. It is given orally. Dosing examples for strongyloiditis is a common regimen of 200 micrograms per kilogram once, often repeated after 2 weeks. For onchocerciasis, the dose is 150 micrograms per kilogram once. This dosage is typically given annually during mass treatment campaigns. Because it's so potent, even a single dose can greatly reduce the parasite burden. So, how does it work? Ivermectin targets glutamate-gated chlorine channels in the parasite's nerve and muscle cells. Binding to these channels causes an influx of chloride ions, leading to hyperpolarization of the cell membrane. This results in paralysis of the parasite, preventing it from moving or feeding, and ultimately causing its death. This mechanism is highly selective for parasites. Humans lack these specific channels in their central nervous system. This is important to understand why the side effects aren't too notable. So, ivermectin does not readily cross the human blood-brain barrier at therapeutic doses, once again contributing to its safety profile. However, when should it be considered? It is generally safe at the recommended doses, once again because it doesn't cross the blood-brain barrier. The most common side effects are dizziness, fatigue, and transient itching or rash. It's avoided during pregnancy. It is in pregnancy category C. Unless the infection is life-threatening, then obviously benefits outweigh the risks. It is also not approved for children under 15 kilograms or infants due to the risk of neurotoxicity. In the case of mild to moderate liver or kidney disease, no dose adjustment is needed. Patients on multiple medications typically have few drug interactions with ivermectin, but we always review concomitant drugs to avoid unexpected CNS depression. The Mazzotti reaction. This is an anti-inflammatory response that can occur after treating heavy microfilarial infections, especially with onchocerciasis. When large numbers of microfilariae die rapidly, the immune system reacts. Patients may develop fever, severe headache, intense itching, dizziness, hypotension, and muscle of joint pain. Symptoms usually begin 12 to 36 hours after treatment, and it's important that patients are warned that fever and itching may occur as a sign that the medication is working. We manage severe reactions with antihistamines and corticosteroids to reduce inflammation. Ensuring adequate hydration is important, of course. In rare cases, with very high parasite load, the reaction can be life-threatening and may require hospitalization and IV steroids. Always consider pre-treating with steroids if a heavy load of parasites is suspected.